All right. So, honest conversation. In reality, Kubler-Ross's stages may not actually be reached in order. A lot of people who have faced death or a terminal illness have gone back and forth between, denial and then anger, and they might bounce back and forth between those two for a little while. They might periodically throw in a little bargaining, and then back and forth with the denial and the anger, and then maybe start to move into some depression, and then bouncing back with bargaining, and like that. They may not be reached in every order, and they actually might not be achieved at all. There are a lot of people who, go down fighting. I mean, honestly, they don't want to accept their terminal diagnosis. They want to fight that terminal diagnosis. And, we really encourage people, particularly with cancer diagnoses, but, other kinds of diagnoses also, to fight. And it's inconsistent with Kubler-Ross's stages to encourage a person to stay in the sort of angry, a little bit of denial, honestly, to be fighting, to be saying, this is not terminal. You're wrong, doctors. I'm going to fight it, and I'm going to show you. I'm going to be in the 5% who survived this rather than the 95% who succumbed to this. I'm going to fight it, and so they may never achieve acceptance. They may, the treatments may all fail, and they may die still, angry that this happened to them. Does that mean that they had a bad death? Like, what is Kubler-Ross trying to say? So a lot of people really object to Kubler-Ross's 5 stages because it kind of makes it seem like if you don't, sorry, my dog's barking, because if you don't go through the 5 stages in order, that you will never have a good death. Sorry, my husband's coming home. So some people who have a terminal illness want to know the truth. They want to be told, exactly what they have, what their probabilities are of surviving or dying from it, what the progression's going to look like. They want to know. And other people really want a rosy outlook. Like, tell me the good news. Tell me what my likelihood of survival is. Don't tell me the other side. And so different people need kind of different information. And so when we talk about having an honest conversation with a person who has a terminal illness, when you really, as a person who might be delivering news, need to figure out what kind of news they really need to hear. Some of them need to hear all the details, and you might be thinking, oh, I don't want to tell you these, kind of depressing things, but if it's what they need to hear, they need to hear it, right? And other people want to hear, okay, what's my probability? What are the treatment protocols? What are the likelihoods of success? And they don't want to be hearing, what are the likelihoods of failure? They don't want to be hearing those things. And so it's really important, any of you who are thinking about going into the medical professions, to kind of feel out what that person really needs to hear. Because you'll have all the information as the medical professional, and you might need to tell them what they need to hear. I am not a proponent of knowing information and withholding it from a patient. I'm not a huge proponent of that. But, delivering what they want to hear, especially during that time where they might be still in the fight. Most people want to spend time with their loved ones in the terminal phases of their illness. Some want to spend time with their loved ones at certain times of day when they're feeling better, maybe between treatments and things. I had a dear friend who was fighting lymphoma, and so I wanted to go and see her, but I said, I really want to come when it's not going to be a burden on you to have me come see you. So we figured out which day was like between her chemo treatments where she was tending to feel her best and like that, we really worked on it to make sure that it wasn't an inconvenience to be, hosting someone, right? You want to be being supported by your loved ones. Now, part of dying in acceptance is recognizing when an illness might be terminal or life limiting. Palliative care is the large umbrella of treatment that we call the kind of care that helps to manage symptoms, so that the person is as comfortable as possible while fighting this life-limiting illness, and trying to live as long as they can, even with this life-limiting illness. Hospice care is a special case of palliative care where you've got that same symptom management, but it's also about comfort care, and it's really reserved for those people who are at their end of life. Different definitions float around, but in order to get sort of your publicly funded social worker to come see you, and the hospital bed to be brought to your house, and all these kinds of things that'll happen for free during hospice times, you have to have terminal illness with an expectation that you probably won't live more than about 6 months. So hospice care is not a special kind of treatment. I had a student once who was very unhappy when her grandmother died in hospice because she thought hospice was like the special skilled care that was going to save her grandma's life. And that's not what hospice care is. It's about making the person comfortable as they are facing the end of life with a terminal illness. So let's talk a little bit about hospice care. Terminally ill patients are going to receive palliative care as part of hospice because one of the big goals is to keep the patient comfortable. Even if they're no longer receiving treatments and they're like, I don't want to do chemo anymore, or I don't want to do anything to try and extend my life. The hospice nurses are able to administer medications and things to help keep them comfortable. This can produce an ethical situation because of what we call the double effect. Oftentimes, to help a person feel comfortable, they're going to be prescribed opiates. And a lot of times it's like the strongest ones we have, like morphine. Might even be fentanyl, which we all hear in the news all the time. There are fentanyl patches that you can be administered, so it'll give the dose correctly so you don't accidentally overdose the fentanyl, because it just takes a microgram off and you can kill the person with it. But these opiates are going to help relieve pain, but they're also potentially going to hasten death, right? Because opiates do a whole bunch of stuff to our bodies that can shorten the lifespan, even in a healthy person who's using opiates. And so it's like this ethical situation. Sometimes a person is in enough pain that the amount of opiate that it would take to actually hit that pain and make it so that the person can, think clearly for a second, might be enough opiate to actually kill them. And so it's a really an ethical situation. My brother-in-law is a hospice nurse, and about 10 years ago, the law changed for hospice care in his state, where now the RN was qualified to determine whether the opiates needed to be increased. They no longer needed a medical doctor's signature on increasing dosages. And my brother-in-law was very concerned that he would accidentally kill somebody. He was very upset by the prospect of accidentally killing somebody. And now it's been about 10 years. He's more accustomed to it. Nothing bad so far has happened. And so I think he's more accustomed to it, but he was terrified. He's like, I did not sign up to be making these decisions. That's what a medical doctor is for. I'm here to fulfill their prescription. And so he was very upset about that. It is an ethical conundrum. Now, with hospice comes this whole circle of care. Now, notice in the center is the patient. The patient is the center of everybody's attention, but next to them are the friends and family. And so the external ring of the different professionals, they are there to treat, first and foremost, the patient, keep them comfortable. But honestly, it's the friends and family who are going to be left behind, who need to be cared for also. And so you have, of course, your physician or your nurse practitioner and your registered nurse and a hospice aide. You have like these people who are attending to the healthcare issues of the patient. But then you have, not only for the patient, you have availability of like religious figures like a chaplain, but also, social workers and music therapists are oftentimes part of hospice care, and volunteers who will come and sit with the patient so that the family or friends can like get a little bit of a break, or, and then there's grief counselors for the family and friends that are left behind. So there's this huge circle of a whole bunch of professionals that can help the patient transition, for their end of life, and then also the friends and family who are left behind and, a little bit shocked and need some care also. When my father died of cancer a few years ago, it was so much support for my mom. Like she needed these professionals, and the social worker was her number one person that she really was just so grateful that the social worker came. There are two principles that guide hospice care. The first one is each patient's autonomy and decisions are respected. If they've written it down, that's the best. If a patient has already done their end of life planning, that's best. But if not, the hospice team will confer with the patient if the patient is lucid and can convey their wishes, because they are at the center. And then for family and friends, they will be counseled before the death about like what the process is going to be and what their loved one is likely to be feeling, experiencing during the process for end of life. And they also are shown how to provide care because the professionals aren't always there. Usually with hospice, you're going to be in your own home. There are some hospice centers that you can go to, but most people want a good death and they want to die surrounded by their regular surroundings and stuff like that. And so their family and friends are the ones who are going to be providing sort of the day-to-day care, up to and including oftentimes administering the medication. And so it's important for them to be shown how to do these things. And then they are helped after the death also. It's not like the team just leaves when the patient dies. The team stays there and provides grief counseling and helps with funeral planning and other kinds of things so that the family members are not overburdened. Now, advanced directives, I kind of alluded to that in that last little conversation. Advanced directives are where a person writes down specifically their instructions for end-of-life medical care. Usually you want to write that before you ever need it. And so it's kind of really an uncomfortable thing to think about as a healthy person, to be thinking about writing, don't resuscitate me. You might have seen an episode of Seinfeld where Kramer watched a movie where a woman was in a coma for years. And then when he's like, oh, I don't want to be stuck languishing in a coma. And so he started doing all of his end-of-life planning. And he realized he couldn't use Jerry as his end-of-life planner because Jerry couldn't even give up his broken tennis racket. So he gets Elaine to be his end-of-life planner. And they were going through like, what kind of life would be worth living? And they came to the conclusion, as long as he could still go to the coffee shop, his life would be worth living. So it was, a comedic take on, the decisions that you have to go through. Like what would your life have to be like to make it worth still living, kinds of questions. And it's really uncomfortable to ask and think about it. Just to give you the spoiler alert on that show, at the end, he finishes watching the movie and realizes that the woman actually came out of the coma. He goes, I didn't know it was possible to come out of a coma. So he was really upset that he had, planned to die if he entered a coma, and then to find out that he could have lived anyway. So you write it down before you need it. One kind of advanced directives is a living will. Where you actually say what kinds of medical intervention you would want if it turns out that you're ever incapable of expressing those wishes. So if you don't want, drastic measures to be taken to keep you alive, you can put that in a living will. And you can say, okay, you can do CPR, but don't put me on life support. Or, you can have whatever you're willing to have listed there. Another advanced directive is what's called a healthcare proxy. And that's what Kramer was assigning Elaine as, right? She was the person that he chose to make medical decisions if he became unable to do that. And he picked her because she would enact what he wanted rather than trying to, no, let's save him. And so, picking a healthcare proxy is a really difficult decision because you do have to pick somebody who you think will actually do what you want, who won't override your decisions, hide your living will or something so that their decisions can be carried out. So you have to really pick somebody who you can trust and talk about it with them beforehand and let them know what your choices are and that honestly, this is what I want. All right. I'm going to go ahead and stop here and wrap up with one last piece talking about hastening or postponing death all in one big fell swoop. So I'll see you in the next segment.